Our next speaker this morning is Dr. Roger Bedimo. Roger is with us today from University of Texas Southwestern Medical Center, and he's the Chief of Infectious Diseases at the VA North Texas. His research interests include the analysis of rates and mechanisms of chronic complications of HIV disease and antiretroviral therapy, as well as the contributions of HCV co-infections and other co-infections on HIV-associated morbidity. He is the clinical research site leader for the ACTG network site at UT Southwestern and is a member of the DHHS HIV treatment guidelines panel. And he's going to do NOMO FOMO. For those of you who don't know what that means, ask him in case you missed it, and will provide us with his discussion on recent updates in guidelines, new publications, and updates from recent conferences. Yeah. Roger.
Thank you so much, Connie, for the kind invitation and introduction, and thank you all for attending. Let's all start with a millennial lexicon, FOMO, fear of missing out. And apart from HIV and others, I also try to specialize in the research of causes and cures of FOMO. And I would like to present one of those results today, and the other lexicon, millennial lexicon, is YOLO. You only live once, so better take advantage of this, including in this lecture. So what I would like, of course, what I don't specialize in is the use of this. And these are my disclosures, and we will have a bit of a potpourri of things that have been recently presented, recently published, that we think are of special interest in driving our practices, and that may not be covered by specialized lectures this morning and afternoon. And some of this will be a bit overlapping, and this is purposeful. And so what we try to go through is looking at our progress towards ending the HIV epidemic and all the pillars that go towards ending the epidemic, and what is our chance of success, and what's our track record thus far. And then we'll look at the trends in survival of people with HIV, and then looking at some select management of treatment-naive and experienced patients that are not covered in other presentations, and also prevention and management of opportunistic infections, focus on syphilis, which is coming back, unfortunately, and then non-AIDS complications. That includes cardiometabolic risk and weight gain that has been already discussed briefly and will be discussed at length in the afternoon by Dr. Srinivasan. And then we'll conclude with some updates on COVID-19. So first, the progress towards the end of the HIV epidemic. And this is what we have been told we needed to do to get to the end of the HIV epidemic. That is a 75% reduction in new HIV infections in 5 years, and at least 90% reduction in 10 years. And we are not on track, but the pillars that we need to focus on: diagnosing all people, treating all people, preventing as much as we can, including PrEP, that Dr. Bookbinder will discuss at length, and then responding quickly to potential outbreaks. Let's look at PrEP first, one of the pillars. What has been presented, published in the U.S. Preventive Service Task Force last year may have gone unnoticed, but there are some important differences. And one of them is that there is inadequate evidence that any of the HIV risk acquisition tools, assessments, do work. So you cannot look at someone, calculate anything about the sexual behavior, drug use, or otherwise that will tell you how risky this person is on acquiring HIV. So, which means that we need to be very liberal in providing PrEP. And the second important thing is there's no age cutoff. There's nothing magical about 65 years, which was the CDC cutoff in 2006 already now. There's no magical cutoff. It's important to actually focus on older patients for two reasons. HIV diagnosis is frequently delayed in them, and they tend to have a steeper decline in CD4 count. So let's think about that. And then finally, I'd like to emphasize one fact about PrEP. The biggest barrier in PrEP is us. We need to be more comfortable with it, and we need to have familiarity. And also, the perceived risk has to be explored, that what its limitation is a perceived risk. Dr. Bookbinder will get to this at length, but this is just a, a synopsis of what PrEP can do. This is a population level decrease in new HIV infections depending on how much PrEP is used in the community. So it does actually work, and we need to be more proactive in using it. In fact, as an infectious disease specialist, more than half of patients that we start PrEP on ask for PrEP to the PCP, and the PCP say, I don't understand what you're talking about, go see the ID doctor. So we need to see how we can improve that. So data from the CDC, so this one allows me to talk about the second pillar, which is treatment and early initiation of treatment, as well as effectively suppressing viremia. And it's also an opportunity for me to ask everyone to pat themselves in the back, because we looked at, if you look at this CDC medical monitoring project data, looking at outcomes of people with HIV who are cared for by HIV or ID physicians, such as myself, and everyone else, non-ID physicians and nurse practitioners, physician assistants, and we look at, how likely are outcomes to be different. The first thing is that there is a higher proportion of people with characteristics of social determinants of health associated with poor outcomes with HIV in those who are managed by non-ID physicians. So they take care of the toughest cases. Despite that, they have similar outcomes in terms of virologic suppression and the like, but even better, they have a higher proportion of the patients who are retained in care and had STI testing, and if they're sexually active. So that means that they are providing a better rapport with the patients, which is conducive to retention in care, and they're taking care of other things than just giving them HIV medication. So that's really important. Another unmet need in terms of ending the HIV epidemic is prevention in women. And PrEP in women has had a checkered record in the past. And this is a synopsis of studies that were helpfully summarized by Dr. Landovit. If you look at the proportion of the body figures covered in blue, which is the proportion of efficacy of PrEP in these people, you see that in women, we have had suboptimal efficacy, low efficacy in many trials of oral PrEP as well as dapivirine ring. So that has been a concern. Is that because adherence was low in many of those studies, as has been shown, or is there a biological reason for lower efficacy of PrEP? So Jean Marasso, who's now at the NIAID, has done a nice pooled analysis of 11 studies of oral FTC TDF PrEP in 6 countries. And the findings of this study has been very reassuring. It's not a trial, but at least it is reassuring in the fact that the sweet spot that we have seen in oral TDF PrEP in males from the IPREX studies and others was that if they took at least 4 of the 7 weekly pills, they had a protection that was as good as those were 100% adherence. Very similar data that she came up with in this, that individuals with consistently daily or consistently high adherence, which is 4 to 6 doses per week to PrEP, experience very low HIV incidence. So daily FTC TDF PrEP can work in women. Fortunately, we now have other options, including injectable PrEP with HPTN 084, which has shown very good data on women. But important to not be swayed by the potential of failure if you wanted to consider PrEP. Safety is also alleviated, or concerns for safety were also alleviated by this line of its analysis of FTC TDF PrEP in 28 countries from 2011 to 2019. So the two things that people are concerned about the most with TDF use are renal and bone toxicity. So when they looked at this in these patients, they show very low adverse events, bone and renal adverse events in these populations. So another thing, let's use PrEP. We're not using it enough. We should not be concerned about its efficacy in women, and we probably should not be concerned about its efficacy, its safety in the bone and kidney. So a further issue on safety was this changes in renal function for PrEP participants in Kaiser Permanente who switched from TDF to TAF. There was a non-significant increase in EGFR when they switched from TDF to TAF. So it was not significant, but other studies might need to be done, as many people on TDF PrEP have been switched to TAF to see if that has actually resulted in improvement of the renal function or the bone tolerability. So people with HIV are living longer. This is thanks to very effective antiretroviral therapy, and Dr. Wooten presented to you that we're making even bigger progress in longer acting, in 10 or 15 years ago, we used to pompously call it highly active antiretroviral therapy, and that pompous definition is actually accurate. It's highly active. It does work if you use it. So what, however, remains is that we need to make sure that the people who are surviving longer with antiretroviral therapy actually live healthy lives as they survive longer, free from comorbidity and otherwise. So this is a very hopeful message. If you look at these curves, the curve in, is that yellow or orange? Yeah, orange, is the general population. And people with HIV start in the gray curve at the bottom. Their survival, the gap between the gray line and the orange line was large in 1996 to 1999, and that gap has narrowed progressively every 5 years. This is up to 2014. Denmark is great because the whole darn country is in one giant database, so they can analyze a lot of things very easily. And so, but what happened since 2014 is that things have continued to get better. Survival has continued to increase, and this is the latest analysis. Unfortunately, there's too many curves, but just look at the fact that the solid lines are those who initiated antiretroviral therapy after 2015. And you can see that especially those who acquired HIV through sexual intercourse, in women on the left and men on the right, we have a narrowing of the gap of survival between people with HIV and people without HIV. And that narrowing has continued. And what then drives the gap? How can we close the gap? And that is what is the topic of further research now. You know, I think that antiretroviral therapy is the low-hanging fruit, and it's been picked by shorter people. So what we need to do now is reach out to higher fruits. How can they live healthier lives after you put them on therapy? So one of them is the burden of comorbidity. And it's been vexing to think about the number of comorbidities that people with HIV get. They're at higher risk of getting cardiovascular disease, bone fragility, cancers, and you name it. So the question is the mechanism of that. But one main thing that has been a little bit challenging is this concept of accelerated aging. It was like if you get HIV, you switch to dog years, so one of your years is actually 7. Now, we think that this has come from people looking at inflammation markers and others, markers of immunosenescence, but us at the VA, we are at the forefront of aging at the VA. And we have thought that this is probably, while they have a higher risk of these comorbidities, they acquire them at the same age, median age, as people without HIV. And so that's what we think, that people with HIV have increased of several age-related complications, but the median age of onset appears to be the same as those without HIV. I'll come back to that in newer analysis of prostate cancers in people with HIV in the VA at the end. However, there is this concept of epigenetic age advancement. And so what that means is that when we're young and we get born, we have clean DNAs and there's no junk around our DNA. As we age, we have a lot of things that don't go so well. And one of them is what they call histone methylation, things around the blueprint itself, the DNA, that may impact what proteins are translated and what happens. And this DNA methylation has proven to be a very accurate way of looking at your real age, not just your chronological age. So that is something that they've started looking at in people with HIV. And again, this was reassuring, even as people with HIV tend to have a high burden of comorbidity. This epigenetic age advancement did not accelerate in people with HIV compared to baseline. So when they look at this, it's sort of a refined biologic clock, this epigenetic age advancement. I would probably have given, so what you see on the right are different tools, the measurements of that age advancement. And if you're going to look at something that measures something related to aging or getting old, please don't call it grim age, like the one they have it at the far right. So this, however, that epigenetic age advancement is important in telling you who's more likely to have comorbidity. So if you measure this epigenetic age advancement, you can see that people who have a worse score there had more neurocognitive changes measured by MoCA score. They also had more risk of dying. And they were, the trend towards them having more advanced frailty as well. So it's a useful tool, but it doesn't mean that people with HIV have an accelerated aging. However, that accelerated epigenetic age advancement, as measured in this tool, can predict your risk for comorbidities and your risk for dying. So that's the bottom line. Again, people with HIV don't have advancement of the aging, acceleration of the aging, but if you look at measurement of aging, they're correlated with the burden of comorbidities that they have, including risk of death. This burden, I know we all have baggage in life. You know, some have a little suitcase, some have a U-Haul of baggage. As we age, we accumulate baggage. People with HIV tend to accumulate more. And so in this forecast, which is pretty ominous, by 2030, it's estimated that almost half of people with HIV will have 2 or more physical comorbidities. And just think about, with that comes more drugs, more complications of drug interactions and the like. Almost 2/3 will have at least one mental comorbidity. And so how can we improve that? This is what we need to do. Now, Managing treatment-naive and experienced patients, this has already been covered, so I'm not going to belabor the point. Dr. Wooten had much nicer slides, and she had more longitude on this latitude trial. So I will not talk about that any further. And she also mentioned that the IAS-USA guidelines actually is now making this recommendation to consider these long-acting agents in people for whom you're struggling to get them virologically suppressed. So now let's move on to prevention and management of opportunistic infections. And this will again be discussed at length by Dr. Bookbinder. But just one alarming fact is this dramatic increase in congenital syphilis in the US. That is incredible. Look at these numbers, 755% increase in just 9 years. And lack of timely testing and adequate treatment during pregnancy has contributed to 90% of the cases of congenital syphilis, which we only saw in books, study medicine. You will be seeing it because it's so much more prevalent. And that is something that we need to be aware of. And the one wonderful discussion that Khalil Ghanem did at CROI is highlights the fact that syphilis is still largely a data-free zone. Everything else that I presented to you, there were trials and studies and such. Here, expert opinion. However, there are a number of things that you will encounter, like people with elevated LFTs, mostly alkaline phosphatase with syphilis. This is syphilis hepatitis, can happen. Do not touch it because you will spread the spirochete, but those things will melt with treatment. Ocular and otic syphilis, the bane of our existence is a consult from ophthalmology that there is uveitis, this person needs not just be treated with an LP. They don't need an LP. If they don't have CNS symptoms, they don't need an LP. And that's important. There are some reasons why they will get an LP. And the follow-up of RPR is another bane of our existence. RPR is stubborn. It's not going down after we treat it. Main thing is wait. If you haven't waited a year, 1 year, you probably haven't waited long enough for the drop. Not that you want to be cavalier, but it's important to wait, and then consider reinfections, pregnancy, and other. Lastly, another thing that will be talked about is the doxypep. It's a thing, and it's doxypep is a thing. However, when you're going to put people on doxycycline, be mindful of the fact that it's going to mess up your interpretation of RPRs. So that is the thing that we don't know what to do with it. I just want to, I don't have answers. I only have questions. So we need to think about it. And then non-AIDS complications are what drives a lot of morbidity. I'm just going to touch on a number of things in these non-AIDS complications. All the tools that predict cardiovascular disease are lousy in the context of HIV. And we knew this for a while. What is even worse is that those tools, thanks to Reprieve, which is a gift that is going to keep giving, and Dr. Eber will tell you more about it, those tools don't predict HIV similarly in men and in women, in people in high-income countries and low-income countries, so we're completely at sea. So the bottom line is this, that this pool cohort equation, which we're using now, and which will be changed in the next few months, they're coming up with yet another tool that they say this one is better. But it's under-predicted events in females, in blacks, and also in participants in high-income countries like ours. So Reprieve will tell us if there's going to be a better tool for predicting capacity in people with HIV, which is one of its gifts. So we have visited this issue of antiretroviral therapy and cardiovascular risk with protease inhibitors, with abacavir, and that story has not seen an end. This is yet another analysis suggesting that the risk of MACE, which is major adverse cardiovascular events, is higher with protease inhibitors, and this was presented in CROI. So what do you do with all this? Consider not using these agents in people already high risk. So that's probably the bottom line. The other thing being that with our appreciation for weight change with integrase inhibitors, it was important to find out whether they are also associated with real cardiometabolic risk. And these are some reassuring data that dolutegravir did not affect insulin sensitivity. This is the euglycemic clamp study in vitro, but also this study that looked at incident diabetes with switch to INSTIs. Neither of the INSTIs, dolutegravir, bictegravir, elvategravir, raltegravir, was associated with incident diabetes. Though these are reassuring data, again, there may need to be more data for us to be completely reassured, but this is where we are. Now, this is a drug that some cities will put in drinking water, and everybody will move there. And these are the Ozempics. So, I mean, if they tell you that my city has fluoride, but your city has Ozempic in their drinking water, and so the thing about it is that it has really, this is the first time we've had weight loss drugs that actually do work. And so, including in people with HIV. And this important study by Jordan Lake at CROI shows that it actually also decreases the intrahepatic triglyceride content, which may be important in now what they call it, metabolic associated steatotic liver disease. It's been called NAFLD, muffled, muscled. It's the same disease, I think. So, but if you're going to use it, be mindful of the fact that it also has onwards, I mean, in fact, it's not only going to decrease your fat mass, it might also decrease your lean mass, i.e. muscles. Again, Dr. Srinivasan will expand on that more. But it's a cautionary tale with a patient who are getting older and are frail. So frailty is a thing in HIV as well. So, and then I finish out in the HIV thing with this prostate cancer. It's just say a couple of facts. One, they acquired prostate cancer at the same age with or without HIV, but diagnosis was delayed in people with HIV. They were diagnosed with prostate cancer at an advanced stage, and so we need to be more proactive in testing and screening for prostate cancer. Even if prostate cancer is one of strange cancer, the concept of HIV has not been shown in many studies to have a higher risk in HIV than in non-HIV, unlike many, many other cancers. And so this is just what this study shows. We diagnosing prostate cancer later and at a higher stage in people with HIV. So let's finish up with COVID-19. A couple of things is who is left behind as the pandemic has moved on. We've moved on, but who is left behind? People with immunosuppression. Vaccines don't work on them, and up to now, there was absolutely no monoclonal antibodies that was preventive because of the new variants having escaped Evusheld. So now there is a new one, and so we need to know that these immunocompromised people are the left behind. They're accounting for a huge proportion of the hospitalized and the dying in COVID. They still haven't gotten their fair shake in this pandemic. So this new monoclonal antibody has filled a critical void, and it's been tested and then approved by the FDA over bioequivalence, i.e. it produces as much immune response as you would expect to be protective of COVID. So that's the bottom line. And this is an excerpt from the FDA approval. It's the problem that I want to focus on. Now the problem, the issue is at the bottom in blue. Infuse over a minimum of 60 minutes. So that's not something that you do at home. It's a high dose, single IV infusion. had to be repeated every 3 months, but high risk of anaphylaxis. So a lot of people are trying to see if it's worth it if somebody's risk was not very high because of that high risk of anaphylaxis. And so close on with COVID, in the nirmatrelvir ritonavir, we have used it because it has had fantastic efficacy in people who had high risk of COVID. This is a study called EPIC-HR, high risk in that. But there was another study, EPIC-SR. They were started almost the same time. However, we haven't gotten the data of the second one, the EPIC-SR, until recently. So we had used, the guidelines have recommended ritonavir-boosted nirmatrelvir as first line in people who have a high risk of progressing to severe disease and dying. However, with the data on the second study, EPIC-SR, which were either people who were either vaccinated or did not have high risk, did not show any significant benefit in terms of time to sustain alleviation of symptoms or adverse events. So that's sort of what we had in terms of potpourri of HIV and a little bit of COVID. So thank you.
Okay, we have time for questions from our experience with FOMO. So as you can tell, Dr. Bedimo is a very entertaining speaker. Oops, I think so I'm going to start with just a reminder, we will have a break after this Q&A session, a 15-minute break. But before we go to the break, we're going to have Q&A, and I have a few more audience response questions to go over with you, just to torture you all before you go off to coffee. First question for you, Roger. Would you recommend any additional preventative health screenings for people with HIV who are on medications like Ozempic, given the potential side effects that can come from consistent use of GLP-1 inhibitors?
Oh, well, thank you. Part of that question I will punt to this afternoon's presentation that we focus specifically on that. However, what I would like to say is that it's not so much side effect as a fact that even if most weight loss is fat loss, there is some lean mass loss. And so if you don't have a lot of lean mass to begin with, that may be an issue. And this is not limited to HIV. This is something that has been found in the general population as well. So exercise is important, and other maintaining, all the things that we have been recommending people with HIV to do to stave off frailty should be emphasized even more. That's what.
Great. While we're waiting to see if there are any other questions from those of you who might want to come to the microphone, I want to probe a little bit some of your COVID comments. And given the data that you just showed for people who are at low or no risk for complications of COVID, what do you tell your people with HIV regarding the use of nirmatrelvir, ritonavir, or other medications that may come along for treatment of COVID?
Yeah, so that's a good question. A couple of things for people with HIV when it comes to nirmatrelvir, ritonavir. The first one is an incredibly long list of drug interactions. Thankfully, many of people with HIV are no longer on boosted agents, but that may be something to work around. The merciful thing is that it's a short treatment of 5 days that you can go back to the things that you can safely interrupt. The second issue with is that should they be included as people at high risk i.e. Benefiting nirmatrelvir ritonavir more. Now, that's, so if you look at many of the studies sparse out the so-called EPIC-SR data, a lot of the people who were vaccinated, so the group of vaccinated had some high-risk people, and most of those high-risk were, transplant recipient and others. So there were people who were arguably higher risk of progression than people with HIV, but who still, even in subgroup analysis of people at high risk but vaccinated and people at low risk unvaccinated, there was no significant impact in that. But I still would recommend people with HIV to take because we know that even if this data is now a little dated, they were at higher risk of progressing and dying. But COVID is, talk about dog years. 1 year of COVID is like 7 years because in 2021, the data is now hopefully outdated, but at that time, people with HIV had much higher risk of dying. But risk of dying in studies of COVID back then, risk of being hospitalized or dying were in the teens, like 15%. It's less than 1% now, so it calls for a nuanced approach, I think.
Yeah, I agree. Going back to your comments on ending the HIV epidemic, it seems like even with PrEP, and we'll hear this afternoon a lot more data about PrEP and PEP and doxy-PEP, that we still have an appreciable number of new cases of HIV. And what are your thoughts about how we can further bend that epidemiologic curve to the point where we really are having a major impact on reducing the overall number of new cases?
Yeah, it's a great question, but it means being granular with our understanding of the epidemiology of HIV. Number one, who is, where do we have the greatest number of cases? Well, let's focus on one of the pillars, the prevention pillar. The higher number of cases are in the South, and the higher number of cases are in Blacks and Hispanics. The higher number of cases are in the young people, young age group. And South, Blacks, young have the lowest use of PrEP by far. So what they call PrEP to need ratio, looking at incidence of HIV and the use of PrEP in the community, is abysmally low in the South. It's abysmally low in the groups that are most affected. So I think targeted approach is where we should go to next. How do you do that? The implementation science may need to be called on, and maybe the dialogue has had flaws in that group, and also the fact that the data presented about outcomes of people with HIV who are cared for by non-infectious disease physicians suggests that we, ID physicians, do a lousy job of keeping people in care, i.e. suppressed for a long time, and taking care of the wraparound services around them. So if we lose them, they're viremic and they transmit.
The microphone?
Yeah, I'm still puzzling over the epigenetics of the situation. Does that mean that patients that we've been taking care of for the last 20 years who have been undetectable because PIs did such a great job initially, that they haven't had premature aging because they've been undetectable? I mean, is it when people are undetectable, they don't have these histone proteins clog up their DNA? No,
that's not. Yes, thank you for asking that because it calls for clarification. I evidently haven't been clear. So, number one, people with HIV have higher risk of a number of comorbidities, a number of complications: cardiovascular, liver-related, kidney-related cancer. Now, the determinants of these risks, to me, I want to think of it as a triad. people come to HIV with a lot of risk factors. People with HIV are more likely to smoke, for instance, and that is a fact. So may not have anything else to do with HIV. And then comes HIV as a second group of determinants, which increase your inflammation, immune activation, that we know, and that these things are associated with a higher risk of these complications. Not necessarily because you have aged, but because it's a more inflammation in your system. Then come the third possible group of factors, treatment. You're not going to have a luxury of living long enough if you're not on treatment. Now we know that some treatments are associated with risk. So what I would tell the patient is that you are at higher risk. It's not necessarily because you're dropping faster in the cliff. The epigenetic age advancement means that accelerated aging means that your aging is faster. You're just a little further along. I don't know if you see the clarification.
But you're saying that they, I thought that you at least implied that if they're well controlled, that they don't have, that they don't have increased rate of epigenetic
okay,
aging.
no, yes. That's not, despite being well controlled, people with HIV still have a high risk of a number of things. Let's take cardiovascular disease, for instance. Viremic people and those with low CD4 count have higher risk of cardiovascular disease than those who are virologically controlled and or high CD4 count. However, the latter they also still have a very high risk. It's important to control the virological, the risk remain high. There's no doubt about it.
So maybe we can have you clarify with each other during the break. We have one last but hopefully very brief question, and then we'll go to our audience response questions. There's currently a lack of clear guidelines on how to screen for prostate cancer. How do you screen your patients for prostate cancer?
Yeah, that's a great question. We don't, there's no, that I don't have clearer guidelines than the U.S. Preventive Service Task Force. and I don't think that there's a need for screening guidelines specifically for people with HIV. So that's the, the PSA is still, I use, and I think it's better than, I don't know if there's a greater efficacy for PSA and digital rectal exam. So that's plead my ignorance there.
Great. So thank you very much to Dr. Bedimo for an excellent presentation.